Okay, hello everyone. This is Sean Lin from the Glaucoma Center of San Francisco, and welcome to our webinar on MicroPulse Transscleral Laser Therapy after incisional glaucoma treatments. I'll tell you about our all-star lineup, but I just want to make sure that you know the focus of our talk today will be the MicroPulse use in patients who've already had a procedure done, particularly incisional glaucoma treatments, as well as people who've already had continuous wave cyclophotocoagulation as well. So you'll hear presentations related to each type of scenario. And please, pay attention to each speaker because they're all going to come at it from different approaches, have different indications, as well as different treatment parameters for treating these different patients. So I really look forward to our speakers. We have over 500 registrants for this meeting. We encourage questions. Please use the question and answer box. And if we don't get to your answer, we'll hopefully get to you by typing back your answer, but we're probably not going to be able to read off every single question and answer all of them, through our discussion, but we'll try to get to as many interesting questions as we can. So I'm really looking forward to our speakers, and here they are. We've got an all-star lineup of my colleagues, Dr. Jella An, who is an MD and MBA from the University of Missouri. She is the medical director and director of glaucoma division and the fellowship program at the University of Missouri. She's been using MicroPulse TLT since 2016 and has contributed to many research studies using the MicroPulse laser. Dr. An recently received her master's in business administration recently, so we're all very proud of her. We think of her as our MBA all-star. Dr. Annalisa Orosamena, I hope I pronounced that right, Annalisa, joins us as a glaucoma and anterior segment surgeon in private practice in Miami. She trained at Tulane under Dr. Ramesh Ayala and is an early adopter of the MicroPulse laser. And we also have Dr. Jacob Brubaker, who's a glaucoma specialist and president of the Sacramento Eye Consultants. And actually, I'll start us off with an introduction and sort of an overview of MicroPulse. And then my colleagues will give you their sort of cases, as well as an overview in those particular situations of post-MIGS, post-tubes, and after continuous wave laser. So let me start off with the device, the Cyclo G6 laser, referring to 6 different glaucoma potential functions with the laser. So you have I use it for 2 main functions: for the continuous wave laser in eyes that are usually blind, painful eyes with very high pressures. I also use it more frequently for the MicroPulse TLT. And this is an example of the TLT probe. We're actually going to be talking about the newer probe, which I use exclusively at this point. And so the treatment techniques, one basic principle difference in the treatment techniques is that with the MicroPulse P3 probe, you actually have the probe on the surface of the eye, but the actual laser is approximately 3 millimeters behind the limbus. So you're actually treating the pars plana area, and that has to do with the mechanism that could be a little bit different from the traditional G probe, which is really trying to, in a way, laser photocoagulate the ciliary processes. But you may have a more effective approach in some ways by increasing uveal scleral outflow with the MicroPulse laser. Also, the application is very different in the sense that with the G probe that most of you are familiar with, you have discrete individual spots, typically about 15 or 20 spots per eye that you treat. With the MicroPulse laser, it's a sweeping motion so that you don't keep all the energy localized in one area, but you will actually apply it slowly over a course of applying it to different areas of the eye. This is the newer probe, and again, I use this exclusively. I really liked it. I was consulted in terms of the development of it, and so I'm really proud that we have one that's in a way ergonomically easier to use and easier on the eye, I feel as well. We'll talk a little bit about that. So it's called the Rev2 probe with the curved foot plate. And this is how you should place the probe. There's what we call the bunny ears, the longer end of it, where you actually put that towards the limbus, and it's made to have a curvature that sort of fits the limbus so that you know that's where you're supposed to be up to the limbus. And then the heel of it is the part that goes away from the eye toward the eyelid And you want it to be basically conform to the eye, not necessarily pushing too hard, but you definitely want to have contact and a little bit of pushing down. There's also the aspect of the laser is at this area here, and there's an area for fluid channel to actually have fluid go in and be coupled with the laser energy being distributed. And if you don't have that filled with liquid, as you have also with the old probe, you actually won't get transmission of the laser. You know, if you shoot it in a way in the air, it won't go through and then penetrate through the sclera to get its effect. You really need that coupling. And I like how the coupling and the fluid channel is recessed so that the goniosol or the coupling agent can actually fill in there, and then you will have coupling with the eye as well. As you'll see in the older probe, that laser probe tip actually sticks out a little bit. You again need the coupling with the coupling agent as well as the eye. But I think you have a better coupling with this newer design, which also causes less, in a way, possible trauma to the eye as you're going back and forth. So this is the older probe. Almost everybody's using the newer probe. I've had plenty of experience with both. And I think with the older probe, not only does it, stick out a little bit, so there may be, you have to work at sort of making sure that it's coupled and have goniosol at the tip, but also there can be a chance to actually have a little bit of effect on the conjunctiva. And some of us have had subconjunctival hemorrhages before, which with the newer probe, I really haven't seen because of the tip of the laser being recessed. This is a great image of how it's actually applied, sort of a cartoon way of looking at it. So you apply again with the bunny ears toward the limbus. And I want to emphasize this part, which we'll emphasize in almost all the talks, is you want to go slow. The original recommendation was 10 seconds from one area of the limbus, 3 o'clock, say, to 9 o'clock, and taking 10 seconds. But actually, you want to slow that down to 20 seconds, where actually I do 10 seconds per quadrant, which is, again, the same speed, but it's actually very slow. And I'll show you a video of that in just a little while. Here's a comparison of the energy levels and the parameters for each type of probe. With the older probe, you used 2,000 milliwatts. With the newer one, you need a higher energy setting, 2,500 milliwatts. And we did 80 seconds above and 80 seconds below with the older probe. And both are the same 31.3% duty cycle. But I want to tell you, it's sort of an update on the newer probe. It was originally recommended to do 50 seconds per hemisphere for 5 passes, but actually the company now recommends slowing that down so that you actually do it in a lower number of passes. And so what I do is I do 50 seconds per quadrant. And so that 50 seconds now is so slowed down, that in their 5 passes that you actually are moving very slow. And I do 50 seconds per quadrant, 4 quadrants. That's 200 seconds altogether. And I'll show you in a little while just how slow that 10 seconds of each pass is. In terms of where you do the MicroPulse laser therapy, I've done it both in the office and the operating room, and I really prefer the operating room. In fact, pretty much exclusively I do it in the operating room, mostly because of the discomfort. Again, if it's an emergency and you really have to do it right away, you can do it in the office. And I've done that, as I said. Sometimes you get referred and you be a patient with a pressure of 50 and you need to do something right away. But if you can, I would prefer if it was myself, because of the discomfort level and the availability of anesthesia, I would do it in the OR-based settings. You don't have any pops. If you do have any pops, then you're going too slow. In a way, you're keeping that probe there and you're getting too much energy transmitted. Again, it's a sweeping motion, avoiding the 3 and 9 o'clock positions. I've done quadrants at this point. It's a little bit better control for me than to have to do a whole hemifield. These are some of the surgical pearls, some of which I've mentioned. You want to aim for the center of the eye, both with the older probe and the newer probe. So you want to make sure that you're not tilted so much that you're aiming, too posteriorly or too anteriorly. You want to have it just right with both probes so that ultimately the laser is aiming toward the center of the eye. You want to, again, make sure you're keeping it on the surface and not lifting up on the eye. And you do want to push a little bit in, not just on the surface of the conch, but a little bit of indentation. Again, critical is to use a viscous coupling agent. And this is, if you just do it, let's say on a dry eye, you're really not going to have an effect with the laser because you need the transmission. And again, a key that you're going to hear throughout these talks is to go slow, slower than originally recommended with the older probe. Here's a case. Let's see if this video plays of a case I just did recently. I think it was 1 or 2 weeks ago with one of my colleagues. And you won't see the tip of the probe too well here, but the goniosol has already, actually I use lidocaine gel, by the way, which also gives anesthesia as well as the gel-like effect. But the key of what I want you to see in this treatment of the infranasal quadrant is just how slow I'm moving. And so for that 10 seconds to go from one part of the quadrant to the other part of the quadrant, that's a long time. Those are almost like micro movements. I almost am barely moving. But that also allows for this laser in a way to take so that there's enough energy transmission for there to have an effect, whether it's through cyclodestruction or through increasing uveal scleral outflow.
So it might be a little bit painful.
So you can tell it's just, and this person is receiving, anesthesia, just probably propofol, just to keep them under for the 5 or 10 minutes that we need to do the procedure, probably closer to 5.
That's a point.
In terms of the results, this is probably the longest term results. Paul Chu's one of our colleagues, glaucoma specialist out in Singapore, and he's a developer of this, by the way, and he has patients that now go out to about 6 or 7 years, and you're just seeing the IOP reduction. These are people with more severe glaucoma, as you can see. So the effect can go out even many years. Often you need to retreat those. So these are people treated on average about 4 times, but you've seen a reduction in number of medications as well as the intraocular pressure. And I think each of us will give our sort of results as well. And so I'll give you some of our results that we looked at. It's been a while now that we've looked at our results, but these were some early results that we had. I was an early adopter as well. And so these are my patients who were at UCSF, where I was at. And you can see a sort of baseline IOP of 24 in our patients. My patients were not usually these blind, painful, very high pressure eyes, but they were patients who number one diagnosis was primary open angle glaucoma. Most often they had good vision, and this was in a way, a more gentle way of doing cyclophotocoagulation that can preserve their vision as well as have an effect. So with the baseline pressure of 24, we went to an average pressure of 17, and this was with a follow-up of 6 months or more. And you can tell that's statistically significant, about a 7 millimeter IOP drop. If you look at IOP response in terms of success rate, with IOP being 20% lower or more, that was achieved in about 2/3 of patients or more, about 68%. So that's what I tell patients. The majority of patients will have a lower eye pressure, but there is going to be a subset where the pressures don't go down. And I think that's important for patients to know. Number of medications, basically, I had about the same number of medications, but that was a little bit by choice on my end. I basically kept patients on the same pressure lowering drops, and sometimes you can back off, but I probably chose to keep them on the same and get a lower pressure. You have to be aware that there are potential complications as with any procedure. So if you look at it from the bigger context of trabs and tubes and all the other procedures, yes, there's going to be some risks involved. Actually, I did not see the majority of these, but I think it's just something that we all have to keep in mind. These are the same risks as you would have with the continuous wave laser. A very small percentage will have unexplained vision loss, hypotony, ptysis, I did not see any of those. Inflammation and redness, all of us will see. With the newer probe, I'm seeing less of it, by the way. And also I am seeing less of complications in general. Cystoid macular edema, I did not observe as well in our case series, but that's a potential risk as well. Choroidals, hyphemas, an IOP spike from the inflammation that you induce. We also looked at anterior segment OCT and UBM. So I'm just showing you a UBM showing before and after, and they look about the same. That is the case, is that we were looking for any structural damage, and we didn't see any structural damage. We're gonna, one of my former fellows, Dr. Chansen Pech, will actually report some other effects on the anterior segment, and you'll see that coming in a later paper as well, which may point to some of the mechanism by which this works. Now, how MicroPulse works as opposed to continuous wave is that you're actually taking that energy, which is in a way, just like in a way, a small nuclear bomb. It's a good amount of energy that you're producing on the eye, and you're chopping that up into little packets of energy. So you're having some relaxation time in between for the tissues to recover on a micro level, so that you don't have to deliver so much energy to achieve the same effect. And I was telling you about the proposed uveoscleral mechanism, and you see that here. This is a primate model. There's also human cadaver models where you're seeing an increase in the uveoscleral outflow and an increase in that space, as well as increased space in that area of the uveoscleral pathway. In the big picture, where MicroPulse fits in for me, and I've done probably 5 of them in the last month, is that, it's really nice to have is somewhere in between, when you treat with medications and you need more effect, maybe trabeculoplasty can work, or maybe it's already been done. And on the level of MIGS, may not replace trabeculectomy per se, but actually I've done it in cases where I considered trabeculectomy, and it really, in a way, saved the patient or pushed off the need for trabeculectomy to later. Of course, you have the option of doing a G probe, but actually I do that even less because the results with MicroPulse, I think, are probably about the same. So in summary, for my section, the diode transscleral cyclophotocoagulation, the continuous way with the G probe, usually I reserve that for blind, painful eyes, very high pressures. Now it has transillumination, by the way. And the MicroPulse TLT is really a useful tool in refractory glaucoma. And I've noticed that the new probe has less inflammation and possibly less risk than with the diode. And again, the new probe really, I think, has made the ergonomics as well as the profile for risk a little bit lower. So let's see if there's any questions. What we'll do is we'll take some questions in between, but we'll probably save most of them toward the end. And if there's no questions, we'll go on to our next speaker. So Dr. An will be our next speaker.
Thank you, Dr. Lin, for your excellent presentation and introduction. So hi, everyone. I'm Jella An. I'm a glaucoma specialist at University of Missouri. And let me just advance it here. I'll be presenting the outcomes of a MicroPulse TLT in patients with a history of failed MIGS procedure and various other glaucoma procedures, with some examples of a dose optimization, which is critical in achieving the best results. So let's start with the case. This is my patient, 78-year-old Caucasian Missourian female patient who is still working full-time. She's still in good health otherwise. She's coming in with the increasing irritation and light sensitivity of both eyes. She has a POAG, mild to moderate in both eyes, a little bit worse on the left side, as you can see in the visual field, with a history of a poor response to SLT, and already had a Schlemm's canal MIGS procedure in both eyes about 6 months back, which worked really well, but still required to use preserve-free COSUP, dorzolamide timolol, in both eyes, which has been the only glaucoma medication that she was able to tolerate until recently. Now she's coming in with this clear contact dermatitis of both eyes, likely due to COSUP, off medication just for 1 week, and her IOP is 25 and 31, which is well beyond her target IOP based off on her history. So we discussed that she's probably heading towards a filtering surgery very soon in both eyes. But after discussing pros and cons, learning more about what's involved in the post-operative period, she voiced her real concerns, which is that she lives more than 2 hours away. She's a sole caregiver for her sick husband who recently had a stroke, which requires a lot of heavy lifting, and that she cannot afford to take too many days off. So she was saying, I'm not having a surgery. If I go blind, I go blind. Thankfully for her, there is another option, which was a MicroPulse TLT. There are several advantages, in fact, using this technology to a filtering surgery. First, there's a minimal to no downtime. and minimal required follow-up. I usually see them about 2 to 3 times within the first 3 months after laser. It is truly dropless. I often do a dexamethasone injection at the end of the procedure, but probably that's not even necessary. There's practically no risk of infection and very minimal risk of vision-threatening complications. It is repeatable and non-scarring. So even if the patient later decide to have a filtering procedure, you're not really burning bridges or by scarring down the conch. The procedure is really quick, about 5 to 10 minutes, and easily be done in the office setting, although I also prefer to do it in the OR setting with a little bit of a propofol because it can be uncomfortable. But MicroPulse has been a lifesaver for so many patients during the COVID lockdown period and throughout the entire pandemic, because we had a shortage of PPE initially, and the OR time was really precious. So it was a great alternative and sometimes a bridging option to surgery to prevent the glaucoma progression during this time. The limitations of MicroPulse TLT include longer time to IOP lowering. Usually takes about a month to maximize the effect. So if the pressure is 50, for example, it's unlikely that you're gonna get a significant response right away. IOP reduction is modest at best. Literature shows about 20 to 45% IOP reduction. And it's unlikely that you'll be off all medication with a recommended setting. Patients often need to be retreated after about a year or two, but retreatment appears to be as effective and safe as the initial treatment, according to our study. Neovascular glaucoma patients don't seem to respond very well to MicroPulse as opposed to continuous wave. They tend to relapse faster with not much of an IOP reduction. However, it can still be a great bridging option for those people who cannot do immediate tube surgery or who's at higher risk of inflammatory or hypotony complications. Out of several hundreds of patients that we treated in our center, we only have about a handful of patients who had persistent inflammation and/or CME, and all of them had a history of uveitis in the past. So a caution is needed in this population. So for this patient, she agreed to proceed with a laser instead, starting with her worst left eye. We used 2,500 milliwatts and 120-second total duration. So that's 3 sweeps per hemisphere with 20-second velocity each times 2, because we treat upper and lower. At week 1, her IOP is already reduced down to 19 from 31 pre-op. So that's about 39, 40% reduction. Given that she had absolutely no issue with this energy setting, we decided to do the same thing on the right eye, which also had about 40% reduction, now the final IOP of 15 and 18. I've been following her since then for more than a year or two, and she's still doing really well in IOP of a mid-teens on no medication with a great quality of vision in both eyes. Let's do another case. This is a Mr. AR, also my patient. He is a 60-year-old African-American businessman with a moderate POAG in both eyes. He has an extensive surgical history in the right eye with a phaco trap with the mitomycin C several years back, followed by blebitis. Thankfully, he was caught early, so was able to save most of his vision. He then went on to require infranasal bare belt, which unfortunately eroded several times, required repeat repairs with the scleral patch. So he really has this inflammatory predilection. As predicted, he has a recurrent chronic CME of that eye, which is maintained on daily NSAID topical. In his left eye, he had an angle surgery combined with the cataract surgery, which has been doing well on 4 classes of medications. His baseline vision has been 20/50 OD and 20/20 OS with IOP in mid-teens on 4 classes. But now he's presenting with a significantly worse vision on the right side with recurrent CME. So he was started back on topical steroid, pred 41% 4 times a day. Thankfully, CME started to respond to steroid, but unfortunately, he's now having a steroid response. As you all probably know, patients like this can be very challenging to manage and can become a catch-22 between dealing with the CME and steroid response. And, it can be a losing battle if you're not careful. So with the history of a poor wound healing, post-filtering procedure, and increased risk of endophthalmitis, we decided to go ahead with the MicroPulse TLT as the next step. We treated with the right eye with the lower end of the recommended dose, which is 120-second total duration, or 3 sweeps per hemisphere times 2, and kept him on QID dosing of the Pred Forte as well as NSAID. 1 week later, IOP is already coming down with no worsening of vision. At 1 month, IOP is down to mid-teens, so we were comfortable increasing the steroid to Durosol QID. 2 months later, CME is completely resolved, and but IOP is back up to 30. So at this point, we decided to repeat the treatment with a higher recommended dose, so 200 seconds, which is a 5 sweeps per hemisphere times 2. And we thought, if the CME gets worse, it gets worse, but we can't treat it until IOP comes down. Luckily, his IOP came down nicely without worsening CME, and we were able to taper down the Durosol without recurrence. At that point, he was so happy with the result of the right eye, he begged us to do the same thing on the left side. So we did, but this time with the medium range, 180 seconds, because we didn't think that it was necessary to go all the way up to 200 seconds. So that is a 4 sweeps per hemisphere times 2. And it turned out to be just right for his left eye. So at his latest visit, he achieved the IOP in low teens, still on the same 4 classes of medication. He probably can take off some medication, but we decided to keep him because of the high risk and no complications or recurrence of CME. So I was using these cases to really describe the benefit of dose optimization in successful IOP lowering using MicroPulse TLT, while still minimizing any complications. So current evidence suggests that optimal total energy for MicroPulse TLT that balances efficacy and safety ranges between 100 to 150 joules. Total energy joules is determined by total treatment duration in second times power in watts times the duty cycle, which is 31.3%. Of course, if you use a higher energy over 200 joule, it will lead to a higher percentage of IOP reduction. So studies show approximately 40 to 60% reduction. But there are reports of moderate to severe vision-threatening complications with this energy, similar to what you see in a continuous wave CPC. So you may want to reserve it for those people with a poor vision, requiring significant IOP reduction, such as NVG patient, because it is still safer than continuous wave CPC, or even filtering surgeries in some patients. On the other hand, if you use a lower energy level, so below 100 joule, usually it deliver about similar IOP reduction, about 20 to 30%, but the effect is shorter. So you would need more retreatment at shorter duration of time. So these are great for patients who need a bridge therapy, those people who have a high IOP but cannot proceed right away to surgery, or those people who you are particularly worried about inflammatory complications such as young uveitic patients, as long as they understand that they may need to retreat it with a higher energy. It's important to note that although there is a dose-response relationship to total energy, it may not be linear. And there are other variables that may significantly affect the outcomes, such as positioning of the probe, velocity of the sweeping motion, and other patient factors, just like any surgery. So what's recommended now with the Rev2 revised probe is that keep the power at 2,500 milliwatts with the duty cycle of 31.3% as constants, and dose escalation by adding additional passes, starting from minimum 3 passes up to 5 passes per hemisphere times 2. So that is 60 to 100 seconds per hemisphere times 2, which because you are treating both hemisphere unless there's a contraindication such as bleb. This equals a total energy delivery between 94 and 156 joule, which is within that sweet spot, balancing efficacy and safety. It's important to go slow, as Dr. Lin mentioned, 20 seconds per hemisphere or 10 seconds per quadrant. So that is twice as slow as the original recommendation. So spend about 1 millimeter per second. It's also important to minimize the breaks between sweeps in order to deliver that constant and sufficient degree of a thermal energy to the target tissue to ensure more uniform treatment. Anyone who is familiar with the endocyclic photocoagulation knows how important it is to treat every valleys and crevices in order to achieve the best outcomes. So it's a similar concept for MicroPulse TLT. So in summary, MicroPulse TLT can be very useful at any of the stages of the treatment algorithm for glaucoma patients, especially in those patients with a failed or insufficient response to various incisional surgeries, including MIGS, who are at higher risk of additional filtering procedure, or those people who are having difficulty with the post-op care, use of medications, or close follow-up. Given its superior safety profile, it can also be offered to those with a very good visual potential. The dosage of the total energy determines the IOP lowering outcome and complication rate. And repeat treatment appears to be at least as effective while maintaining the safety profile. The long-term durability, so over 6-7 years, and the effect of multiple sequential treatment still remains to be studied. Thank you.
I'm sorry, Dr. An, thank you for that great presentation. I actually had a question for you before we go on to the next speaker. Have you seen pupillary dilation? That often comes up as a concern after MicroPulse, and have you seen it long lasting?
So there's a 1, maybe 2 patients who had a pupillary dilation that lasted more than 2 weeks, and both were uveitic young patients. Eventually came down, but those were the 2. Now I often don't see them until about a month later. So maybe that's why I don't hear too much about it, because eventually it does get better. But I think it is a part of that inflammatory response.
Okay, I agree. I've seen cases where it usually then comes back to normal after a month or 2. Thank you very much for that great presentation. Dr. Rosamena is going to speak to us about MicroPulse TLT before and after tubes. Annalisa?
Thank you for having me. First of all, I want to say that my heart goes out to all the victims of the horrible building collapse here in Miami. It's touched us all. We have lots of ophthalmology friends that had friends and family in it. So with that, let's get started. I have a few disclosures to mention. And to me, the biggest thing about this laser is how safe it is. I am the main glaucoma surgeon, actually the only glaucoma surgeon in a big practice. And having this in my armamentum, it's super important. So to me, the safety of the new probe especially has made this, I mean, you said you did 3 last week, I'm doing 5 or 6. I mean, it's very common because I tend to use it more often now. The no downtime for the patient, it's very important. Younger patients cannot take off of work, cannot stop lifting for 2 weeks. So that is also important. And we said it already, it's repeatable. And I can always do more surgery. And I don't use any of the reals. So if I need to do it a month later, 5 months later, 5 years later, I still have that real estate open. And in some patients that I need really low pressures, I will combine it with other procedures. If I'm taking the patient to the operating room, because as you guys, I do like a little propofol. To the difference, I do a little propofol and a peribulbar block on my patients. So they are very nice and sedated when I do it, because I've done them in the office and it does tend to be painful, even with subconjunctival lidocaine and with lidocaine gel. So my go-to, as with you guys, is to do it in the operating room. And when I combine it, I do a needling or a blood revision at the same time. On who do I do it? Well, sadly, everyone is a candidate. From the patient that is intolerant to a raw kinase, like the first photo, or a patient that needs a drug holiday, because I'm planning on doing incisional surgery and I need that patient to have a healthier conjunctiva, to the patient with dermatitis that needs only one drop off, or somebody that has a tight orbit that will be very hard to put a glaucoma drainage device into. I also tend to use it in neovascular patients. I do believe CPC, continuous wave, is better for these patients. But as you are gonna see in some of my case presentation, I will do it to quiet the eye. I think that an eye that is inflamed, angry, with active pain will do worse with any kind of surgery you do. So by doing a MicroPulse Transscleral Laser, I am able to lower the pressure, quiet the eye, and give a little extra time for the eye to heal. Patients that have large bleps that you need to treat inferiorly, yes, we have an infranasal valve to go to, but I wouldn't want one in my eye, so I will always try MicroPulse first. And as good as this patient looks, 2 tubes in the eye will have endothelial cell count loss. And on the long run, we'll end up with a corneal transplant. So even a phaco mix on this patient, if I only need a few points, I may hold on if the vision is good and go for MicroPulse instead. Also, as I said, patients that have a bad cornea, I just did one last week. I don't want to put a tube and then do a DSEC a week or two later on a patient. And as you mentioned, I am anterior segment, so I tend to keep that cornea good as long as I can, ergo my use of the MicroPulse. The second patient I'm showing here is a patient that went to Nicaragua and had some infection, according to the referring doctor, that came in with this severe scleral melt, pressures of 30. In this particular patient, MicroPulse saved the eye because there was no way you could do any kind of incisional surgery on this patient. And last but not least, as I mentioned, job requirements. No lifting is a very hard thing to do. New mothers, young people that are active, exercise, all of these factors are important when we do big incisional surgery. Even with subconjunctival mix, I've had patients that did lifting and ended up with choroidal. So the fact that you have this option, it's key. So how do we get it to work? I think we're beating this a lot because in every single one of our talks, we've mentioned it. But I think most of the mistakes and most of the complications that people saw with the old probe came from not positioning the laser correctly, came from treating the 3 and 9 o'clock positions, and came from not going slow enough. So my key points are, if you can, avoid the 3 and 9. If you have a big bleb or a bunch of tubes, well, I'll treat it. I'll take as much area as I can treat safely. Number 2, if you have a tube, you can treat easily over the tube area, but I will not treat over any trap. Go slow. It increases the amount of of energy you deliver to the tissue. And as we said, increase your duration more than you increase and play with your energy. And the position of the probe, make sure your bunny ears are right at the limbus and that you're not tilting the probe in any way. Ensure proper exposure. I tend to use a forceps If I have to, if the eye is tight and I don't get good exposure, I will put a speculum, grasp the eye, make sure you grasp only once. If you try to re-grasp for every sweep, you're gonna end up with large subconjunctival hemorrhage or tearing the conjunctiva. Sometimes you get away with a Q-tip, but make sure you have good visibility so your probe is not getting tilted. And as we mentioned, use a good coupling agent. If I'm using an intraocular surgery and I'm doing the MicroPulse combined with needlings or revisions, I use that same viscoelastic. If not, I use goniosol or tear ointment. In this patient, my anesthesiologist blocked the eye. I ended up with a very nice subconjunctival hemorrhage. By now, the patient was in the operating room. You need to know if this happens, you need to increase your duration. The energy will be absorbed by the subconjunctival hemorrhage, and you will not deliver the same amount of energy to the eye. So in these cases, increase your duration so that you can still get good results. And in patients that you combine with any toric IOLs, DSECs, that you mark the eye to see your procedure, make sure you also know that the energy will be absorbed by the marking pen. My post-op management, I've tried to simplify it. I tend to do prednisolone 4 times a day, 5 days, twice a day, 5 days. And I let the patient stop the medication before they come to see me. In patients with early glaucoma, I try to discontinue drugs and reevaluate around a month. But sadly, most of my clinic is severe glaucoma or have other surgeries before. And therefore, I do tend to see them at a week, and I keep all the glaucoma medications in these patients. I love the story. This is a patient that came to me back in 2016. We started doing MicroPulse back in July 2015. And he was part of my first publication about MicroPulse back in 2018. And he's still one of those success stories now in 2021. He presented with 2060 and 2400, pressures of 21 and 20 on maximal available medical therapy, severe visual field defects, severe cupping in both eyes. And as you can see, the right eye had the joy of a supratemporal tube, an infranasal tube, and a DSEC. And my left eye came with a beautiful referral of a sutured IOL, supranasal valve, and a PKP. So what do we do with this patient? Thank God I had already started doing MicroPulse. We performed MicroPulse back in January 2016. At the time, I did go up on the power. I used 2,500 milliwatts. I kept the duty cycle at 33.3%. And even back then, I increased the time and duration. I did 90 seconds per hemisphere. Back then, I was doing around 60 seconds. But on this particular patient, I went up to 90. And as you can see in the graph, this is not always the case, but this is an amazing success story. The patient, as of June 11, 2021, had a pressure of 10 on the same medications with an added rho kinase inhibitor. But even 5-6 years later, his vision is stable and his field has not changed. So always keep in the back of your minds that you have a strong weapon to treat these difficult cases. This second patient was referred to me from the retina service. He's a 49-year-old male. He came with proliferative diabetic retinopathy, neovascular glaucoma, steamy cornea, IOP of 54 on everything, severe pain, and a severe neovascular hyphema injected eye. Retina did their thing. They did an IV Avastin, an AC tap, and sent them to me saying that the patient needed PRP and more Avastin and possibly more surgery, but they just couldn't see anything. So By the time the patient came to me the next day, he was back up at 50s, severe pain again. So we discussed our options. I told him we could do a glaucoma drainage device. And as I mentioned, the cytokines and the inflammation in the eye, we're gonna make this most likely a failure on the long run. We could do continuous wave transscleral cytophotocoagulation, and he was kind of afraid of the consequences of hypotony. He wanted to see if there was anything else. So we offered MicroPulse TLT, and we said, well, once the eye is quiet, we can always do a glaucoma drainage device. The next day, so on day 2 from presentation, we were doing a MicroPulse in the operating room with a peribulbar block. I did 120 seconds per hemisphere. And by post-op day 1, the pressure was 9 and the patient was painless. The cornea still had some edema. But by post-op day 1 week, the patient had no corneal edema and retina was able to go in and start doing PRP. By day 30, the pressure was up. By 1 month, the pressure was back up, but there was no pain. We repeated the Avastin and the patient underwent a glaucoma drainage device a week later. Even though this may not have been a super win, doing the surgery in a quiet eye, as you can see the difference between the first photo and the last, made a huge difference in the outcome of the glaucoma drainage device and in the comfort of the patient. In conclusion, I can use it on everyone, in every part of the spectrum of glaucoma. It's non-incisional, very low risk of infection. We published 197 cases back in 2018. And out of those, we had 4 cases of CME. By now, I've done that amount or more, and I haven't had another case of CME. And I think it was all about the positioning of the old probe. I think people that were hesitant should try the new probe first, because your outcome is much safer. There's minimal to no inflammation, no downtime, is repeatable, and it's a great, great weapon for complex cases. Thank you.
Thank you, Annalisa. That's terrific. Thanks for all those great pearls and those tips as well. I think very, very practical and something that I've kind of learned along the way as well. I'll ask you one real quick question. We have other ones that we'll get to at the end, but since you see probably a very wide variety of different racial groups there in Miami, a question I often get is, do you see any difference between pigmented or lesser pigmented individuals versus more? Do you change your settings or amount of duration?
I don't change my settings based on pigment, color, or race. I do change it based on severity. Okay. And I do tend to have more severe patients of Afro-Caribbean descent here. They have very aggressive glaucoma here in Miami. And I do have a large population of Hispanic patients, but mostly I change my settings based on severity of the disease and what my desired IOP is.
Okay, thanks so much, Annalisa. Our next speaker is Dr. Brubaker, who will talk about micropulse versus continuous wave laser. Jake?
Well, thanks. I'm pleased to be here with all you guys to kind of enjoy learning from you and all the things that I've learned. I would say that I'm probably a little bit of a later adapter of MicroPulse. I started off with the older probe, and honestly, I wasn't terribly impressed with the older probe, but the newer probe has really changed my mindset on MicroPulse. And so I'm doing a lot more of that. But I still do kind of mix up my MicroPulse versus continuous wave. And so I'm going to talk a little bit about why I would choose one versus the other. And I think it's probably similar to what we've already talked about. I'm going to start off with a case. This is a patient that came to see me, a 78-year-old gentleman. He'd already had phaco iStent ECP back in 2014. I did a tube on him initially, and he ended up with aqueous misdirection. Wasn't too happy with me. He ended up doing okay eventually. went back to his referring doctor, and then came back to me, as all good glaucoma patients tend to do. And the eye pressure at that point was now 34 in the eye I hadn't treated and 26 in the one that had the OMID. He wasn't exactly inclined to have another OMID tube, I would say. His vision in his good eye was 20/30, and in that left eye was 2100, and he's on everything. His nerve is still very normal in the right eye at 0.5 and 0.9 in the left eye. And these are his fields and his OCT. So you can see that clearly his left eye was bad from when I first saw him, and still needs a pressure obviously lower than 26. And then that right eye, we need to do something and hopefully avoid another tube. So we'll talk a little bit about that later at the end. Another case, this is case 2. So don't draw your eyes to that OCT, because that's the right eye, that's the good eye. The left eye is actually the one that he's coming to see me with, and we weren't able to even get an OCT on that left eye. So this is a patient that has intermittent pain in the left eye, history of CRVO, referred by a retina colleague to get his eye pressure under better control. So that left eye, hand motion, IOP of 40, on all the drops, kind of, what we see every day, what I see every day at least. Microcystic edema, in hyphema, PAS, PCIOL, no view of the fundus. So what are we going to do in these 2 different patients, and how are we going to approach those? And so we'll talk a little bit about that. So we've already talked a little bit about the G probe and the MicroPulse and kind of the way that they work. I'm not going to belabor the point, but basically these are the 2 probes here. And again, we talked a little bit about the MicroPulse, that continuous wave is kind of this sudden impulse that can give you not only kind of the intended treatment, but also some thermal damage. And that's something that we're able to avoid with the MicroPulse. This is a really great paper that I really like that talks, I did a ocular pathology fellowship, so sometimes I like to geek out a little bit about pathology. And this was kind of an interesting paper that was actually looking at what do we see when we're seeing the kind of differences between these 2 different approaches. Since you can see in the gross histology here that we see in slide A and C, these impulses. And then you also see the thermal damage kind of right in the middle, and that would be kind of representative of maybe a pop that we sometimes hear when we're doing continuous wave. Whereas with MicroPulse, kind of on the right side there, you see this lacy, wavy kind of approach that as that probe goes by, it just kind of leaves that thermal, that damage, but much less impactful as far as causing inflammation. And then you can see again in the histology that the MicroPulse is much more controlled, whereas you see actual damage in the continuous wave. And so that's obviously what we're trying to avoid. So again, we kind of went over this earlier. MicroPulse, obviously much more gentle on the eye. We talked about the bunny ears, we talked about the energy. So I'm not going to bore you with that, but I second everything everybody else said. And I think that some of the results that we had earlier, I have never seen a patient with mydriasis and pupillary issues with the new probe. My response is so much better with this one because I think it's so much easier to control it. It keeps it in the right place, and the energy is directed right where you need to go. Whereas the old probe, it was a little bit more difficult to do that. Again, continuous wave, I think, I still do this. And this is more in those advanced cases that I think really needs kind of that bigger gun. And so for me, the original technique was about 1500 to 2500 milliwatts and kind of 2 seconds per burst, and then titrate below the pop. So you get the pop and then you kind of lower the energy based off those pops. I now do kind of a slow coagulation technique where I start about 1250, go all the way up to about 2000. That's about where I'll stop. And then the duration is about 4.5 seconds, and then anywhere from 15 to 25 spots. And so there was a paper that showed similar results as far as the IOP response, but less inflammation with the slow coagulation technique. But otherwise, it's kind of what we are used to. And then again, MicroPulse, these are those 2 probes, and we already kind of talked about how to line up the bunny ears and get it right. But I've had a dramatic improvement in my response and my efficacy with the new probe. So how do we pick between, why would I pick one versus the other? I think things that I'm considering is their vision and their visual potential. So if they have good vision, good visual potential, it's MicroPulse all the way. If they have poor visual potential, blind, painful eyes, vision maybe worse than 2200, I'm kind of maybe, and really high eye pressure, I may be leaning towards a continuous wave. Their preoperative eye pressure. So if their pressure's in the 40s, I'm less likely to do MicroPulse. If they're kind of in the mid 20s, low 30s, I think MicroPulse is really a great option for them. And then previous incisional surgery, previous TLT, I think that in those cases, sometimes I'm maybe leaning more towards CBC, but kind of depends. And then I think the ability to have another procedure. I do definitely feel like with continuous wave, I have reduced incidence of retreatments. And so somebody doesn't want to have another retreatment. Maybe their visual potential is not that great. Sometimes I'm leaning more towards still continuous wave. And then also the ability to perform a block. I do feel that continuous wave is more painful, not only during the procedure, but then also afterwards. I really feel like I need to give them a block. Whereas with MicroPulse, I think we can very easily get away without doing a block, just giving them propofol. And so if we can't give a block for whatever reason, say they're monocular and they want to be able to see right away, I'm sometimes leaning more towards MicroPulse in that case. And then the status of the other, like I said, if they're monocular, sometimes I'm a little bit more leery of doing continuous wave in that case, and I'd be more leaning towards MicroPulse. And so like Sean said, this is kind of my algorithm, but I would say honestly, over the last, probably since the new probe came out, this kind of gets extended out. I think that MicroPulse is really taking away a lot of what I used to use continuous wave for. I think it's really just kind of those really end the road cases that I'm using continuous wave for now. And so let's get back to those cases. So that first gentleman, so this was kind of an interesting gentleman. I mean, I still have PTSD, remembering trying to deal with his aqueous misdirection, trying to get everything kind of back to where it belonged. And so I was actually pretty happy that I had the continuous wave the MicroPulse as an option. He really wanted to get both eyes taken care of at the same time. He also is a gentleman that has kind of poor ability to respirate on his own. And so the anesthesiologist wanted me to actually have him sitting up during the procedure. We gave him some propofol, let him sit up. I was kind of climbing all over the place trying to give him my treatment, but we were able to give him continuous wave treatment, MicroPulse treatment in both eyes. And he really did quite well. So I used 160 seconds total. So it's 40 seconds per quadrant. And again, same settings as we've talked about. So not quite all the way going up to the 50 seconds and not really that 30 seconds, but kind of splitting the difference. And so I just saw him at 4 months and his pressure is now down to 18 in that right eye, whereas it was in the 40s before, and down to 16 in that left eye. So he's really, really happy. And really happy that he doesn't have to make the long trip to come see me. He can kind of follow up with his regular doctor. And then that other case. So this is one where I chose to go with continuous wave. So in my mind, this is kind of a no-brainer. This is somebody that I would either do a tube or continuous wave, and he elected to choose this. And so in his case, 25 spots, power almost as high as I go, and then the duration at 4,500 milliseconds. And then at 2 months, his vision actually improved as his hypemia resolved, and as what the retina doctors have been able to do helped him out. And so his vision improved to counting fingers, and his pressure is now at 12, still on those 2 medications. So this is kind of my algorithm at this point. So if I'm looking at MicroPulse, good vision, IOP in the upper teens, 20s, maybe even low 30s, those for higher risk of inflammation, and then those that prefer more safety rather than the need for future treatments. And then continuous wave, like I said, pressures in the vision worth in 2200, IOPs in those 30s and 40s and above, blind painful eyes, and less inclined for future treatments. So thank you very much. It's been a pleasure being with you guys, and good luck with your laser blasting. I think this is a great treatment option for our patients. We're always as Annalisa said, we're always looking for those tricks that we can use, those tools to better treat our patients against this really challenging disease. But in this day and age, it's so much better to treat compared to even 5-10 years ago. So thank you very much.
Thank you so much, Jacob. I really appreciate it. Great talk. And I know we're coming up on 6 o'clock, but we can, well, 6 o'clock my time at least. But I think we can go over about 10 extra minutes to get to the many questions. We probably won't be able to get to all of the questions. My colleagues have been kind enough to answer many of them, just on the chat session and also just typing back some answers. But I think the whole group who are listening can benefit from seeing some of those questions and probably have some of the same similar questions. So I'll just ask, actually, we have you up, Jacob, already. So what is your post-op regimen? You probably mentioned it a little bit, but in terms of steroids, maybe injecting steroids at the time, what's your usual post-op for it?
Yeah, so I'm like I said, I'm probably a little later to the adoption circle as some of you guys. So I'm coming over from kind of continuous wave and what I've been kind of traditionally doing. And so in that case, so for those ones for continuous wave, I do give topical steroids. I have them actually taking their steroids for up to 6 weeks on a taper. I have them take atropine in all cases for my continuous wave. But now moving more towards MicroPulse, I don't inject steroids. I don't really like doing that because I'm always leery of steroid response, that kind of something that I've injected that kind of hard to take back. And I think with MicroPulse at this point, really it's tapering down to like 2 to 3 weeks with steroids. And I just use topical and I don't use atropine anymore.
Okay, thanks so much. Another question that was asked was about the issue of vision loss. And I know that that's a concern with any glaucoma surgery, as I mentioned, including the continuous wave, especially those eyes that are, well, they start off blind painful often. So, you can have even further loss from hand motions to NLP, for example. But there have been reported cases. They're anecdotal, they tend to be relatively rare, and I would say my experience has been that way as well, of significant visual loss that happens soon after the laser. Anybody can chime in. Please tell us what your experience is, and maybe the question was actually how to avoid that. And so if you have any tips related to that.
Well, I'll take that. I think in my experience, and I think at the beginning with the older probe, you did tend to have a lot more complications. I think that the position of the probe would determine if you were hitting the iris and getting the pupillary dilation. The position of the probe will also increase your inflammation. My post-op regimen is minimal, and I think the vision loss that some people have seen has also to do with the amount of inflammation you create. I think with the new probe, that is minimal, as I said, and I haven't seen any vision loss from the probe. We reported out of 197 eyes, actually 197 eyes, 4 cases of CME, and I don't think I've had a CME case since I switched to the new probe. So I think it's a lot of positional situations with this.
Well, I think I think a lot of the vision loss that historically we've seen has really been with continuous wave. A lot of times with patients that had more severe disease to begin with. Definitely, going back in time, 8 years ago when I first started practice, I can think of a few patients that really, we didn't have any other option really, and continuous wave was really the only option. And in most cases, I would say it's CME is really the cause of the vision loss in most cases. But sometimes you can get, just like you get with anything, like with a tube or trab, you may have somebody where you did a perfect surgery and everything's doing well, and you might have a little bit of a snuff out or something like that, where they've just kind of gone for their last little, thread of vision and is gone. And so I think that can happen, but with MicroPulse, I agree with Annalisa. I haven't seen it yet. And it doesn't mean that it can't happen, but I think the risk of that is much lower now with this compared to kind of what we were using before.
Thanks. I appreciate all of that. I would say, right, we have to also put it into context. The 2 versus TRAP study had about a 5% rate of vision loss that couldn't be accounted for, 2 lines of vision or more. And I think mostly in the TRAP group. And so, people expect, that perhaps you have a miracle cure. There really are no miracle cures in glaucoma, as all of us know. But, when we hear, sometimes some of our colleagues hear about some vision loss, they just kind of focus on that. But my experience has been the same. It's been very rare. I've done a lot of cases with the new probe, and I haven't seen any significant vision loss with the new probe. Another question that we got was a couple questions related to scleral thinning and also nevus aguda. Annalisa, you addressed this a little bit in your talk. Do you want to kind of let the whole audience know what your thoughts are?
Well, I don't, it's not like you see nevus aguda all the time. But this patient I presented had severe scleral melt. It was terrifying. And the patches that you saw in the photo had already been placed by a previous doctor. So to me, I was hesitant, but this was the only chance the patient had. I was not gonna open the eye under that situation. So I did adjust my power, my duration. I did not change the power, but I did do only 60-second sweeps on that particular patient. And I think she should be coming up to a year now. So I might be seeing or having to repeat it soon, but it would still be my go-to on those kind of patients. As bad as it is, it's better than the alternative.
Thanks so much, Annalisa. Another interesting question was asked by one of our colleagues about doing the MicroPulse in relation to femtocataract surgery. Obviously, with the femto, you often get subconjunctival hemorrhage just from the suction on the eye, and you get a red eye afterwards. And do you do it before the MicroPulse before, or do it after? And do some of you have experience combining it with cataract surgery?
I'll take it again. I don't usually combine it. If I'm taking the cataract out and I'm already in the eye, I'll take one of my variety of mix. I do them all. So I will go for that. It wouldn't necessarily be a MicroPulse if I'm already opening the eye. That wouldn't be my first choice. But in patients that have subconjunctival hemorrhage, do increase your duration because the power delivered to the ciliary body is going to be much less. So do longer sweeps and extend your time accordingly.
And I think also if you have a subconjunctival hemorrhage, I think a lot of times you can push the blood out a little bit. And so if you're pushing a little bit more compression, it kind of pushes out, especially if it's fresh, it'll kind of push it out of the way. And you can actually see as you come off that it's kind of blanched that area. And that usually can help a lot too.
That's a great tip. I've done it too.
Yeah.
And the coupling agent will help you with that.
Thanks. Those are excellent points for our listeners. Another related question just came in are there concerns about cataract development in younger phakic patients? Have any of you done sort of young phakic patients that maybe seen a cataract form?
I've done a few, yeah. I mean, I've been venturing out a little bit more as far as so historically with continuous wave, I would always, if somebody needed a continuous wave, I would always say I'd almost guarantee them that they were going to get a cataract. It may not happen right now, but it would within a year. I think it's almost guaranteed. So far at this point, I don't know how young they were, but I mean, they definitely were people that had 1+ or less NS. And so far, I've been, knock on wood, pretty lucky that they haven't created cataracts yet. Time will tell, but I think it's always kind of that balance as far as what you should do when. But I think it definitely has that risk, but less likely, I think, with MicroPulse.
My youngest patient was 28, and I happened to see her today. I did her when she was 28 and a half. She's 34. And no cataract yet, but I'm dying for her to develop one because she's a -14. And I can't wait. I keep telling her we need that cataract to grow. So I wish he had given it to her so we could get her off those big glasses. But but luckily my youngest one hasn't developed one.
Okay, great. Well, that's good news. That's shows that it doesn't seem to induce a cataract in even our younger patients. Well, we also have a question related to glaucoma drainage devices, and I guess you might apply this also to tubes or trabs, although that's probably going to be a different answer. Is what do you do in that situation? Do you go over it? And I think maybe Annalisa, you talked a little bit about that. So, we often see this with the tube patients. What do you do?
Over the tube, no problem. Treat the whole area like you're treating normal sclera. Over a trap, stay far away.
Mm-hmm.
I mean, far away with the older probe, like super far away, because that little tip would tend to break conch. But with the new probe, I get close, but not over. I don't have the guts to do that. I would stay away.
Okay. Any thoughts, Jacob or Jella? Do you have any other thoughts? Same
Yeah,
thing.
I avoid those areas. I don't think the energy conduction is that great over the tube anyways. And I really want to avoid any, risk of erosion.
Okay. Yeah.
Well, I think it also depends on what the trab looks like. So we've all had trabs that basically look like they never had a trab. So clearly in those cases where they don't have an active bleb, I think you can go over there, no problem, obviously. But anything that's kind of, had poor vascularity or something like that, I would stay away from that area. And then with tubes, I haven't actually to this point gone over tubes. But Annalisa, you've inspired me. I'm going to just go right on over.
I actually like hitting it right there. I have a feeling that there's some peritubular flow that increases when I shrink that sclera zone. I have had great results in two patients. This is actually my go-to when a patient has a previous tube. So.
Yeah, I think for me, I can't say in all cases, but I think the days of second tubes are almost gone. So yeah.
In fact, we're getting out of time, but I'll add a little bit of my 2 cents in terms of the tubes. Following up on what Annalisa mentioned, there's now studies that are published and ongoing studies looking at combining tubes with doing cyclophotocoagulation. That is either at the same time or maybe staggered, do one first and then do the other. It's like you're hitting two main mechanisms of action, outflow and then inflow, and the results seem to be really great. Just to let everybody know, there's just ongoing studies and published studies. So I think that kind of justifies what you were saying. It really works well in tube patients. Well, we're hitting on 6:10, and I appreciate all those listeners who stayed with us. I really appreciate all my speakers and for Eardex to support this. And I hope we answered most of people's questions. Please feel free to reach out to us. I'm sure my colleagues would be happy to kind of give you some tips. I would certainly be happy to give you my thoughts about this as well. So thank you all very much. I really appreciate it and hope to see all of you at the Academy and at other meetings.